Okay, good evening, everyone. Today is Thursday, the 5th of March. Being a Thursday evening, 6 o'clock means only one thing. It means it's yet another time for our clinics webinars. These webinars are meant to spread knowledge amongst the medical professions, fraternity, and they are sponsored by Clinics Health Group. Clinics Health Group has been sponsoring these webinars since 2020, and they are continuing, but they're continuing only for one reason, because you keep on showing so much interest, all the regular people who join us as colleagues in medicine, our especially senior professionals share knowledge on this platform with their colleagues, which we really appreciate. The speakers on this platform do it for free of charge. We give a acknowledgement of just a gratitude token to speakers, but they don't get paid, so they do it out of the love of sharing knowledge. Clinics Health Group pays for the webinars; it sponsors the webinars, so and that's why they come free of charge to all attendees. All you have to do is to register on the invite that we send out, usually with a week in advance, to everyone. You have to register and put in your HPCSA registration or SAMCA, South African Nation Council or Pharmacy Council registration number, and not your practice number, your registration with the registering body, to be able to get CPD points, because they are accredited with HPCSA for CPD points. Thank you very much for having logged in. We will mute you for the duration of the webinar whilst our speaker tonight shares information with you, just so that she is interrupted. But at the end of the webinar, we will allow questions and answers. So answers from our speaker. You will be able to raise your electronic hand so that we recognize you and allow you to make your comments or put questions. You will also be allowed to, during the presentation, to put in your comments and questions in the chat box. You may post your questions and comments in your chat box, and then our speaker tonight will attend to them at the end of her presentation. Today we have none other than Professor Tivani Mashamba-Thompson. Professor Thompson is the Professor of Diagnostic Research and Director of the Center for, she's a founding Director of the Center for Development and Implementation of Point-of-Care Diagnostics with the University of Pretoria. She's a molecular biology medical scientist with a master's in Master of Science, but also a PhD from UKZN. She's been with the University of Pretoria now for about 5 years. She's also an NRF C1 rated researcher. She's professor of and founding director of the Center of Development and Implementation of Point of Care, but also leads the Africa and Europe cluster of the Research Excellence on Multimorbidity. She contributes a lot nationally, and she's a board member of the NHLS, the National Health Laboratory Services, and she chairs in the board of the NHLS, she chairs the subcommittee of the board which for research and innovation. She's also a deputy chairperson of the National Health Research Committee of South Africa. And she contributes a lot on point-of-care diagnostic, which are tailored for resource-limited countries. So it's something that is, you'll hear more what is meant by the point-of-care diagnostics as she continues. But Prof. Mashamba-Thompson, let me hand over to you. I'll mute myself and we will attend to the comments and questions thereafter. All the best.
Thank you. Thank you very much for the kind introduction, Professor. And greetings to all my colleagues, the clinicians, the scientists that are attending here today, and all health professionals that are attending. Good evening. I was requested to speak about a topic that is very close to my heart. Those who work with me know I'm always talking about point-of-care diagnostics and the need to improve access to healthcare. So before I can even go deep into the work that we're doing in researching and research that relates point-of-care diagnostics, I should just define this concept of point-of-care diagnostics. So point-of-care diagnostics are diagnostic tests that are performed near patients or on a patient's site. And these diagnostics, they provide results that can enable immediate clinical decision. And they really help because they prevent the need to send the sample to the central laboratory. And they actually are designed, the tests that are used at point of care are designed to be simple and rapid and portable, as well as user-friendly. So anything that it doesn't meet that criteria, it's not a point-of-care diagnostic result. If it's not simple, rapid, portable, and user-friendly, and also does not enable immediate clinical decision, then we don't fit it into this category of diagnostics. So colleagues, I will proceed then with a presentation which will focus on the following areas. I will talk about diagnostics as a foundation of clinical practice, and also the research focus areas in our Center for Development and Implementation of Point-of-Care Diagnostics, and also address some clinical questions that we focus on in the center. I will also present the guiding frameworks and methods that we use to answer the questions that we're working on in the center, and also show some evidence that we have been revealed from the work that we've been doing over the previous years, and share our strategic vision for South Africa and the next frontier, meaning the work that we plan to do in the near future. So there's also a disclaimer here. So the work that what I'll be presenting to you today is not my work alone. It derives from the research that is conducted by my team. It's a large group of people under the Center for Development and Implementation of Point-of-Care Diagnostics. And the interpretations shared here are for academic and stakeholder discussion. And also, if you want to go deep into finding out more about evidence that you can use to inform policy and practice, we can share with you some of the policy briefs that we have produced. Then feel free to contact me at the end of the presentation today. So diagnostics, as you know, colleagues, it's a foundation of clinical practice. It enables us to accurately, diagnose our patients and detect diseases early, and enable us to also manage the chronic diseases and manage the diseases as a whole. Sorry, my slides are going funny. And with diagnostics, we can also guide treatment decisions and monitor effectiveness of our treatments. With diagnostics also, we can prevent inappropriate and in delayed or harmful interventions, as well as support public health interventions and epidemiology. We've seen this very recently in the COVID-19 pandemic, and we see it every day, in how point-of-care diagnostics particularly are enabling early detection of HIV and also management of HIV without the need of a central laboratory. So, this needs to be underpinned by evidence, and hence we conduct research on point-of-care diagnostics to ensure that we produce evidence that ensure that when they're implemented, the implementation is successful, and also the implementation is sustainable. So point-of-care diagnostics particularly are very critical to our types of settings in resource-limited settings. So these are settings that have poor access to laboratory infrastructure in most cases. And you find in most cases, the resource-limited settings also have high disease burden. So, diagnostics tools such as point-of-care diagnostics are very crucial in these settings, as they really assist with enabling access to healthcare for people who would be generally be disadvantaged. So, overall, diagnostics form an essential framework upon which safe, effective, and efficient healthcare can be built. And we'll be talking more about that in the coming slides. So I want to share a little bit about the research focus areas for our research group or research center, not a group anymore. We were a group for a long time, and we became a research center in May 2025. And our focus is on reassured diagnostics research, and we look at aligning our research in ensuring that the diagnostics that are here or used in South Africa meet the reassured criteria that has been stipulated or put together by WHO to ensure that the diagnostics that are used in our settings produce reliable results. So questions, here are some of the questions that we answer under this theme. We really want to know how the diagnostics can be made affordable, and how can they be made user-friendly, sensitive, and specific, and also to ensure that they are implementable in a real-life setting. And we ask a question that what evidence can we produce to support their alignment to the WHO reassured criteria? So another theme that we focus on is, co-designing our intervention or co-designing the interventions that can help enable their successful intervention. We co-design this in collaboration with stakeholders. And the questions that we normally ask is how can stakeholders and community engagement improve accessibility, uptake, and sustainability of point-of-care diagnostics tools that are made available. Also, which co-design approaches can optimize integration of this point-of-care diagnostics into the local healthcare systems. When I say local, in our context, as you can see in the map here, local is not just South Africa. We have worked beyond South Africa. We've been doing research in Zimbabwe, Ghana, and Namibia, and even Zambia. So we look at how we can optimize these interventions in our region, not just South Africa. And also, we have a theme on global health equity impacts. How can research inform WHO ethical guidelines on diagnostic priority settings? And what strategies can ensure equitable access to diagnostics in our region and other similar settings? And we also look at enhancing diagnostics accessibility and look at what interventions can improve accessibility and availability of these diagnostics in the settings that I alluded to earlier. And we also work on strengthening evidence-based and policy and practice for point-of-care diagnostics. And I'll share more about this. Then we look at, we ask questions such as how can generated evidence guide national and regional policies for equitable healthcare delivery and enabled by point-of-care diagnostics, and which indicators demonstrates an impact on patient outcomes and health systems performance, and meaning the impact of diagnostics that are used at point of care. So as you're aware how research works, what we spend a lot of our time also doing, we don't just delve straight into conducting research or focus too much on research that is is just focused on responding to calls or funder-driven research. We try our level best to spend more time, working with stakeholders and identifying barriers that exist. And some of the common barriers that we have revealed or that have been shown to us, these barriers that in Africa specifically, the common barriers are fragmented evaluation pathways, this evaluation of point-of-care diagnostics once they're made available to us. So the evaluation pathways are very fragmented, and this limits access or limits deployment of those diagnostics to reach the people that need them. Also, we've seen limited local validation data. So there is even when the diagnostics are validated, you find diagnostics are available to us, but you look at the validation data, you will see the diagnostic is validated way outside our region and in regions that are not similar to ours. So that data becomes useless to us, and meaning that there is a need for more validations to be done locally. And also we see regulatory heterogeneity in our region, which causes a huge amount of problem, especially for the local developers or developers that really want to deploy their diagnostics locally to us and enable us to improve access to healthcare. And we have a procurement inefficiencies as well. And we've done a lot of research also in improving this area, and have assessed and evaluated the supply chain management systems, and we've seen there's still a lot. This is one of the areas really that we call a blind spot in a diagnostic system. As I said, we've seen the supply chain instability in the research that we've conducted locally and regionally. And we also have limited digital interoperability. Sorry, it's after 5 for me. So some of the words don't come out because I'm exhausted. And so this is very much a problem, especially where in a context where we are looking at ensuring that all diagnostics meet the reassured criteria, meaning that they need to be digitally connected. And this is important, that the digital connectivity of the diagnostics is important because for a diagnostic to be available at point of care and producing data, and the data staying at that point of care, it means that diagnostic is not contributing to disease surveillance in a country. And also it means, it's not really fitting or suitable for healthcare system in our context. So there is quite a lot that still needs to be done, and technology remain piloted, but not institutionalized. So you'll find a lot of diagnostic platforms or research platforms in South Africa. They've done a lot of work on piloting diagnostics in small regions and in their labs and with their smaller populations that they're working on. But we find those diagnostics are still not institutionalized. They're not even scaled up, and people are not benefiting from it. So so these are the gaps and barriers that we have identified, and that also help guide the research focus areas as well. And in addressing the barriers and gaps and challenges that we have identified, we really try our level best to use implementation science as a catalyst for our research. And it has been very much useful because it has enabled us to really focus more on, designing our diagnostic systems in a way that is human-centered. So we have we have tried our level best also to co-create interventions with stakeholders. Stakeholders doesn't always mean the developers of diagnostics or policymakers or even the users, meaning clinicians. To us, stakeholders include patients. As you can see in the study that we conducted in KwaZulu-Natal and eThekwini, we collaborated with men, urban men, and here we were looking at trying to see how we can improve their engagement with HIV services using a HIV self-test, how we can enable the delivery of this approach in a way that can improve men's engagement to the services and help address the burden of disease for HIV in a country. And also, you've seen also you can see in the study that we conducted in Zimbabwe recently, where we also co-created HPV self-sampling approaches with women in rural settings in Zimbabwe, and the implementation research methodologies such as nominal group technique has been, a really good tool to enable us to really engage with the stakeholders from different fields. We don't only, as you can see, these are the underserved populations and usually marginalized populations, and we try to reach out to them because these are usually the populations that they tend to have the high burden of disease because they have poor access to diagnostics as well. And we also collaborated with young women again in KZN to see how also we can improve that self-sampling approach for them, especially in the context of sending STI samples to clinics or directed to the lab. And also we have also collaborated with higher level stakeholders, which are the developers of diagnostics and policymakers, on finding out what are the barriers and enablers of implementing the digital linked diagnostics models. And then we conducted this study soon after COVID, and the focus was to reveal the lessons that were learned from COVID-19 and try and help address the barriers and enablers. And as much as COVID-19 was bad, but for point-of-care diagnostics, it has been a good thing because it has enabled or helped improve acceptability of point-of-care diagnostics. And more people, even at clinical level, they really accept this as an approach for diagnosing their patients, and even people at home now accept even self-testing or more and more of the point-of-care diagnostics methods. They've seen how that has been enabling during the pandemic. We also worked with stakeholders in Namibia, where we were looking at improving interventions for promoting hypertension medication adherence. And this also was a success, and we were able to also design interventions soon after this engagement in Namibia. So this is how also we're using this implementation science approach, this one stage of it. And I will also show you how we also do this in evaluating the accessibility of diagnostics and assessing their performance, as well as look at the uptake in all the settings. We also look at the accessibility in the context of supply chain management. So we've conducted research in KwaZulu-Natal again, looking at operational assessment of these diagnostics in rural settings. And this study that was conducted in KZN, as you can see, this was in 2018, this publication is, but the work was done in around 2016. And this is the study that really helped reveal, the real barriers and enablers of point-of-care diagnostics in resource-limited or in rural settings in South Africa. And from the findings of this study, we were able to also now request for a wish list from health professionals who told us what would be the best, in their settings, which types of diagnostics do they want. And that has been highly useful for the developers of point-of-care diagnostics that are aimed for South Africa, because we felt it was important to also engage the clinics and make sure that the development of diagnostics is not just based on, scientists, interests. That, I really want to develop a diagnostic now for schistosomiasis. But is that what Joburg wants? And where are you going to deploy that in Joburg? Did you talk to the health professionals and ask them what exactly what they want? So it's also important that this assessment of the need is also done regionally, because deploying diagnostics just blind, it also a waste. So a lot of the developers have worked very closely with us after reading that paper, and it has helped them develop the right diagnostics for our setting and different regions of South Africa. And recently, we've also worked on HCV point-of-care test in Ghana, where we were evaluating its performance. What's interesting about this is that, HCV, the target population mainly for HCV, it's key populations. And working with key populations in Ghana can be very tricky because you are not, certain groups of key populations are not allowed to go to be out in the public or known that they exist. Because it's illegal and you can be arrested. So we struggled very much to find participants, but later we realized that it's probably better to look at one group of key populations, which was the inmates, and we were lucky to find a prison that was happy to collaborate with us, and then we're able to test HCV among prisoners in Ghana, and we're then able to evaluate the HCV test. This is also just to it indicates how difficult sometimes to actually conduct these field evaluations of point-of-care diagnostics. In some cases, you find that you have a test, and you do know that there is an issue, the disease exists out there, but finding the population to be able to evaluate it and show the results that can enable uptake or adoption of that diagnostic and scale up can be very, very tricky. And we also, beyond just doing the evaluation studies that requires lab work, we also conduct a special assessment or special the geospatial analysis to look at accessibility of diagnostics. And this is done by our data science team, and really interesting work. And even when you read the papers, you will see interesting maps in the papers. And this is to show the heat maps and just special analysis to show the accessibility, the distance that people need to travel from home and to the healthcare facilities to access the diagnostics. And this is the work that helps us justify the need for increasing or the need for deployment of diagnostics to relevant populations. Because what we've noticed, specifically with the studies that we did in KZN, is that clinics that are even closer to laboratories tend to have higher number of point-of-care diagnostics. And the clinics that are further away from laboratories and tertiary hospitals tend to have fewer number of point-of-care diagnostics. And it doesn't make sense, because point-of-care diagnostics are more useful and much more needed by people who have poor access to laboratories, central laboratories. So what is important, what we were trying to show in the special analysis studies, is that we're doing things the wrong way. It's like, you know, why are we not increasing the number of point-of-care diagnostics in more rural clinics, and where there's even people have to travel too long to get to the laboratory, and they usually, some of their results don't even reach them, because we know of the issues that are relate to getting our samples to central laboratories when we are in resource limited settings. And yeah, so we've also been looking at using evidence synthesis as well, evidence synthesis methods to help us see the accuracy of tests that we can maybe get hold of, or tests that we hope to purchase and work with. It's not always that you need to do a primary study or you need to do the evaluation yourself, especially if a lot of evaluation or studies have been done in regions that are similar to yours. You can gather evidence that exists. That's what most pharmaceutical companies do. Gather evidence that exist, evaluate that evidence, and then make recommendations based on that. After after you've synthesized the evidence and showed the impact and where it matters. So we do use also evidence synthesis methods to evaluate the accuracy or performance of the diagnostics. We also utilize existing data. So we conduct sometimes secondary data analysis and look and present the impact of interventions or diagnostic interventions. So for this one study that you can see here at the bottom, where we were working in KwaZulu-Natal again, it seems like KwaZulu-Natal is my favorite place, but it should be Limpopo because I'm from Limpopo. So we looked at KZN again. We looked at the impact of COVID-19 on TB diagnostic services at primary healthcare clinics. And this was done post-COVID. So you can't look at the impact of COVID when, COVID is still here, but post the pandemic, the heavy time of the pandemic. So we looked at the impact of the pandemic on TB diagnostic services. And we justified this because during the time of the pandemic, we know that a lot of services were affected. Other patients were not getting as much attention, and then TB patients were one such group. So we then used existing data. We conducted secondary data analysis. So it's another method also you can use to evaluate impact of interventions without having to have that intervention happening at the time. Here, in this one, the intervention was COVID-19, so we couldn't simulate COVID-19 in order for us to show that impact of COVID-19. I did mention that I should be talking more about Limpopo because I'm from Limpopo. We did also conduct a study in Limpopo. This was also overlapped COVID-19 period. We were interested in knowing how supply chain management was done during the COVID-19 period, and we looked at evaluating supply chain management of SARS-CoV-2 point-of-care tests in primary healthcare clinic, and this was done in Mopani district. Those who were following the news and data on COVID-19 during the time, you would have seen the Mopani district as one of the districts that was most affected. There were higher mortalities reported in Mopani, and I can tell you Mopani was also one of the districts that had poor access to point-of-care tests. And the tests arrived at some point, and when they did arrive, we were then able to also conduct this study. Limpopo is one of the regions that is predominantly rural, and it does have many rural settings that are far away from laboratories. And I remember during the pandemic, COVID-19, we used only one in the study that we were conducting. We tried our level best to find molecular biology services or laboratories that offered molecular biology services to enable us to evaluate the new point-of-care tests for COVID, meaning SARS-CoV-2 point-of-care tests. It was difficult. We did find one laboratory, and they were able to help. So you can imagine, and they were able to help, but they had a lot of samples as well, because the whole region was limited in diagnostic services, molecular-based diagnostic services, which were needed during that pandemic. So yeah, so we have reached Limpopo as well, and we're doing a lot of work now in Limpopo, and we're looking at studies that look at schistosomiasis as well. Point-of-care diagnostics for schistosomiasis is what we'll be working on and evaluating in Limpopo to help address this disease burden in Limpopo. I'm trying to shift my slide to the next slide, and I don't know why it's jammed. Am I still audible?
Yes, you are still audible, clearly audible,
Okay.
Prof. Try again.
Thank you. Yeah, my slide though is not moving. I don't know what has happened to it, but what I can do.
Maybe use either the side to side or up and down buttons on your keyboard.
That's what I'm doing. Yeah, so it's moving. Yes. Thank you. So what we found in general from the evidence that I just presented there, we found that point-of-care diagnostics the findings that I'm presenting here from many other studies that I didn't show on the screen because I'm only given 40 minutes to talk here. I cannot show you all the 100 plus studies that we've conducted in our center in the past 5 years. But what we have found in general from majority of the studies that we were conducting, we have found that the point-of-care diagnostics are generally affordable, they're user-friendly, and sensitive tools that, in most cases, they meet the WHO reassured criteria when they are designed for the real-world condition. So the problem we found that is that when you find tests that are designed for the sake of showing off science, not with a focus for the real world conditions, they don't meet any of the criteria. You find they're too expensive, they're not user friendly, and yes, they may be sensitive, but what's the point? If it's sensitive and specific but not affordable, it can't reach the poor people anyway. So it's important that you meet all criteria. And also engaging stakeholders and communities has also been shown to be useful in improving the acceptability of point-of-care diagnostics and their adoption and long-term sustainability of these tools. We've also been able to produce policy briefs that has informed WHO ethical guidelines specifically for priority settings. And this is one of the things that we've been very proud of, to be able to be for our research to have been recognized to be good enough to inform ethical guidelines. And this is because we've been seen to be working with these underserved populations, and so the contribution was invited. So also the diagnostics, it's important that they are context specific. We found that also in our research. and the appropriate implementation strategies increase availability and use of diagnostics in our settings. So our findings also, they strengthen the evidence base for policy decision, and they support equitable healthcare delivery and measurable improvements of patient health outcomes. We work very closely also with hospitals. There is a study that we've conducted now at Steve Biko, looking at working directly with patients, we're collaborating with them and getting them to talk to developers of diagnostics and find out what patients actually really want. The focus for this study was mainly on non-communicable disease point of care diagnostics, because that's an area that is also that we see an increased number of diagnostics being developed. So we try to get the developers to come closer to the patients, and that study has been really good. And we hope that is soon after the peer review is done, we'll be able to go back to Steve Biko Hospital and share the findings with the patients. And our findings as well have shown that there are lots and lots of blind spots in this space. There's a lot that still needs to be done. There's a lot that needs to be done in terms of awareness at all levels. We have identified that there's still a lot of, there's something, I think it's a new term that we have coined, is we say diagnostic illiteracy at all levels, and that there need to be interventions to address that. And this illiteracy is mainly on point of care diagnostics. There is still a lot that needs to be done in terms of educating people at all levels on point of care diagnostics, because this is a diagnostic tool that is, it's taking over almost, and that is the truth. It's almost like we're moving away from having the payphones on the corner of the street to having a cell phone. And we cannot slow that down. It's moving. The rest of the world is moving fast. So we need to catch up with educating ourselves on what this is and how can it be implemented and how can we get on board. And also, incorporating this into our curriculum. There's a lot that is not taught. Myself, I'm a medical scientist. I've been taught, I know a lot about methodologies that are from central laboratory methodologies. I've had to unlearn and relearn when I came to research point of care diagnostics. Being a competent laboratory-based scientist may not make you a competent implementer of point of care diagnostic, because point of care diagnostics require knowledge of public health platforms, and our curriculum from my time didn't incorporate anything too much to do with settings that I call point of care, which are in a public health space outside of the laboratory. And also the same for people who are not laboratory trained. Now we are taking the laboratory outside of the laboratory into your point of care, into your clinical setting, into your home, into your pharmacy. We're taking it out, the laboratory, and expecting you to be the user of these laboratory tools without teaching you, without incorporating these methods into your curriculum as well. So there's a lot that still need to be done, and there's a need for us to collaborate and make sure that this is sustained, implemented in a sustainable way. Then I also need to also share that we use the systems framework to help evaluate and adapt and enable the adoption of the diagnostics and accelerate that, which is important. And that also include accelerating, the stewardship as well, because and accelerating this awareness and getting people in getting diagnostics integrated into the health system. So early implementation research is what we're doing, and integrated digital connectivity research is what we do with our digital health team. We try our level best also to work with the regulatory systems for regional regulatory harmonization of the point of care diagnostics, because we know this will be scaled up, and if we scale up this service without appropriate regulatory systems, there's going to be a problem. There's going to be an increase in medical legal cases. It's just going to end up being a waste anyway. So we also try and ensure that our evidence reach the platforms that are working on regulatory systems, and we're also part of the team. So I'm very fortunate to be a researcher and a policymaker, and I am able to now ensure that evidence that we produce also inform policy. We also focus a lot on capacity building. I'm very passionate also about capacitating others, and because in this context of diagnostic or point of care diagnostics, we still need more experts to lead in this space, particularly in our region. I found, for the best part of my research career on point of care diagnostics, I couldn't find friends in our region, in sub-Saharan Africa. I would be working or collaborating with researchers outside of sub-Saharan Africa. So I made it my job to create my own friends and capacitate others. And so we train and train for leadership really in this context. So we look forward to collaborating with you also. For those who want to be trained, we can work together. For those who want to also train us on things, on areas we think we need to know, we can work together. So it should be both ways. So our diagnostic, our Center of Development and Implementation of Point of Care Diagnostics, which we call CPOC DX in short, really serves as a hub within this the ecosystem of point of care diagnostics that enables for the developed diagnostics to reach the market as well. So in this work of accelerating the developed diagnostics to market, we don't work alone. We work with entities such as Africa CDC. We also work with the TIBA platform, which is a regional platform, but it's led in Zimbabwe and Edinburgh University. We also work with Cornell. I'm particularly more involved here in advisory, and I mentor the developers of diagnostics, because the developers of diagnostics in New York, most of them are developing the diagnostics for resource-limited settings. So I make sure that, as they are developing, I share with them the voices of the users in sub-Saharan Africa, and also the patients as well, and the general public, what we really want this side. And I don't just use my opinions. I share the studies that we conducted and really amplify the voices of the people in resource limited settings. We also work very closely with WITS Diagnostic Innovation Hub, and we we're actually part of the MPOX consortium of South Africa, funded by MRC, and we are involved now in developing MPOX diagnostics. And I would not say MPOX has been disappointing, because we are not able to do much in the field because we don't have disease, but we know that we have diagnostics ready. We actually have learned from COVID that we don't have to wait till things are out of order. We are now working, and we're very grateful to the MRC for funding us to do the work on developing and optimizing the diagnostics on MPOX. And we're also working very closely in this work, although we don't have much disease, we're able to get samples from elsewhere, but to be able to validate or evaluate these diagnostics in the field, it's a problematic, and it's the area that I'm supposed to be leading, but it's an area that has to pause until there's enough disease. But that's not the problem. It's something we're happy that there's not too much of a disease. We also work a lot in the Department of Health platforms. So, and they always welcome us in the Department of Health, and we're very grateful for that. So beyond our region, we've been working very closely with Ghana because of our association, or because of me being one of the leads for the Africa-Europe Class of Excellence. So University of Ghana is one of the leads as well. So we're able to collaborate with them and conduct studies in Ghana. So if MRC was able to fund us to evaluate the mpox outside of South Africa, it would be easy for us to just do it in Ghana or in the region around Ghana. But unfortunately, MRC is for South African research, and we have to do it here. So yeah, I did say I will share the strategic vision that we have for our country, South Africa. I know that the audience here are beyond South Africa, but I know majority is from South Africa. So South Africa and Africa, really. So our vision as a Center for Development and Implementation of Point of Care Diagnostics at UP is to really see South Africa or Africa transition from being a technology recipient in terms of point of care diagnostics. We want to see us becoming a technology co-developer. We want to see us moving from being to conducting pilot studies and just publishing in Lancet and all high impact journals only, and become researchers or evidence producers that enable scaled implementation of interventions. We also want to see us moving from our fragmented systems and integrate diagnostics networks in our region. That could really help us. So I'm, as a medical scientist who has been leading this in this space for many years, I've noticed that there's a perception that medical scientists are here in this space in a clinical space just to assist others. And then I hope that with the work that we do, it will help us move from being seen as assistants in the clinical space and be recognized as clinical practitioners, especially here in South Africa. We all know that, medical scientists have been well recognized by the HPCSA. They are part of the medical and dental board among the other healthcare practitioners. So under the HPCSA medical and dental board, we have medical practitioners, we have dental practitioners, and we have medical scientists. So we are together in the same board. We pay the same fees. We should be contributing equally, but unfortunately, the regulatory systems or the governance of medical scientist profession has not been like optimal to enable medical scientists to contribute in a right way and improve, enable South Africa to be the lead in health innovation as well. So this is also an area that we work very closely on and improving this. And I'll share more on that in the work that we'll be doing in the next future or in the near future. So I did mention that there are lots of blind spots in the implementation of point-of-care diagnostics. We have written about them and shared in Nature reviews of bioengineering, but it's not all about just sharing and getting the brownie points of publishing. We also want to work on in those areas. We published because we want to collaborate with others in addressing all those blind spots in the implementation of point-of-care diagnostics. And it's a lot of them, and you can see there's a lot of work for us to do. And you feel free to read this article and then also reach out to us if there's an area you want to collaborate with us on. We also really want to focus more on this population groups that are marginalized. You know, we have started now with the work that is funded by MRC in collaboration also with WITS DIH. I called it's WITS Diagnostic Innovation Hub. Yes, that's not what I called it earlier. So it's because I'm used to calling it WITS DIH and I forget what the acronym stands for. So with WITS DIH, we are working very closely with the homeless population. This is also because we're preparing, we're working to prepare for MPOX. And the homeless population is one of the key population that will present first, and also other key populations as well. So I'm just showing you a picture here of one of the students, Nyeleti, who is leading in this area doing science communication, developing science communication strategies with them, and also with other population groups. And we hope that what we can learn from this will help us intervene very quickly if mpox hits us in South Africa. And in addition to the tests that we already have, when that comes, please feel free to WhatsApp me. We can now intervene very quickly. So we don't just talk about pandemic preparedness. We do the pandemic preparedness, and we have started. So we also have been looking at areas that don't use point-of-care diagnostics already, and there is a need to improve systems there. So there is one of our students, Sibueng, who started a PhD, just got accepted this week. But her master's work was, she's originally from the forensic background, and she wants to look at developing point-of-care diagnostics for use in a forensic environment to help with improving, fast-tracking this forensic death investigations. She calls it unexpected deaths investigations. She's an expert in this area, and whenever you talk to her, she talks forensic. She's very young, and I sometimes wonder why did you get interested in death and not the other side of us being alive. But I got to learn a lot from her, and also understand what still needs to be done. So we collaborating here with the SMU, and then she will be working on developing the diagnostics also in collaboration with Warwick University. We are going to focus a lot on digital linked diagnostics, and also localization of diagnostics that are developed outside. In this work of localization and data localization of diagnostics, we actually will be working with CSIR. They have a huge amount of competency in that. So we have a lot of diagnostics that are developed outside of South Africa, and they are perfect. They look, the experts, they are ahead of us, because for the longest time in South Africa, we have not been looking after the profession of medical scientists, so then we're limited in local innovation. So the other countries that have been looking after the profession of medical scientists, meaning bioengineers and all the molecular biologists, are now ahead of us, and they've developed a lot of diagnostics that we're still thinking of developing. So what we are having to do now, we now collaborating with them to localize the diagnostics. It gives us a little bit of IP, because now we are able to take a diagnostic that has been developed nicely in New York to suit New York, and then localize it in South Africa in collaboration with CSIR. The localization is a process on its own. We can have another talk about that. The digital linkage of diagnostics is key. In fact, when you come to evaluate a diagnostics for suitability of use in resource-limited setting, if a diagnostic is not digital linked, actually should not be deemed suitable for use. So we're working very closely with African Institute of Data Science and Artificial Intelligence here at University of Pretoria. And with this team, we already have a fellow who is Dr. Kutlula Malulek is working closely with this team, and she's leading the data science and working with a smart data scientist there from engineering to help us develop, the apps that we need to have to enable our diagnostics to be suitable and enable digital linkage of the results. We also expanding beyond South Africa. As I said, our work is beyond South Africa, and working under the Africa-Europe Cluster of Excellence makes life easy for us. We have our partners under this Cluster of Excellence, of Research Excellence. We have partners, I said, in Ghana, but we also have partners in Liberia. Liberia is a highly resource-limited setting, and for me, who is constantly looking for challenging areas, I am very much excited about working or collaborating with the Liberian scientists, and also helping develop capacity in Liberia under the Africa-Europe Cluster of Excellence, and also with assistance from Warwick University. So this is what we plan to do in future. Some of the work that we plan to do, there's quite a lot, but this is I think this is the exciting part. But I'm sure it's just my exciting part. I'm sure if you speak to other researchers in our group, they'll give you another area. So that's just for research. The next work that we want to do to influence policy and practice, we know as I said, the diagnostic service task shifting is coming. If we're going to increase the use of point-of-care diagnostics, there will be a need for, task shifting in terms of the users of diagnostics. There will be probably a need for us to move some of us from the lab need to move closer to point of care, and then when we are closer to point of care, we might need some training on how to now talk to patients. I've had to learn a lot on how to talk to people because I came from the lab. I worked in the lab for a long time, and then when I now started studying point of care diagnostics, I insisted I wanted to be in public health. And most of the times I would attend meetings in public health, and I wondered how people could just talk, and there's no science coming up, and I didn't quite understand. And it's now that I understand that it's not just chat, talk for nothing. It's important that you get rapport and all of that. And I can even understand what they write about, I understand. So yes, so we do need to capacitate people who were still like me 20 years ago, and the other way, the other way around. As you can see, we might need to empower clinicians at point of care, nurses, midwives, to be able to read their own results from the microscope. So there's a need now for training on microscopy. Or other methodologies or other approaches that you need at point of care. And so, we need to bring diagnostics to patients, and we need those faster diagnostics. We need early treatment and better health outcomes, and that can be enabled by point of care diagnostics. So in the policy space also, we also want to work closely with private partners, and have some PPP approaches into taking diagnostics to the community. So we see clinics as an ideal partner to work on this with us. Recently, as I think most of us who are following me on this or following University of Pretoria and our faculty, you've seen what we've just recently enabled. So most of in the past, medical scientists were not able to register a practice in a community. So now, with the work that we've been doing to try and influence policy and change in this space, medical scientists are now able to register their own practices and work in a community. But this is a new area for us, but we really want to contribute, and we want to collaborate. And if we could collaborate with partners such as clinics, then it would be really great and help improve health outcomes in the community. And continue working with SAPRA in developing regulatory systems for point of care diagnostics. This is the area that we've already started working on, and work with HPCSA as well to help ensure that the medical science professions are well governed in the same way as the other professions that are in the same board. And we have already started working with AIMS, which is an African Institute of Medical Scientists. They are constantly in contact with the with HPCSA and trying to improve systems. And we know we are a developing country, so things still need to be developed. And the experts that we have here, we want to keep. We don't want brain drain, because we know that in the past, many scientists that are produced by South Africa, they leave and they're better looked after elsewhere. And then we import their technologies again back in South Africa at a higher price. So it's possible to keep them here. So this is just to acknowledge the partners that we work with. There are many partners that we work with, but these are the key partners that maybe like on, most of the work that you see us publishing, we have been enabled by them and working closely with them. I've mentioned some of them, almost all of them in my presentations, but I've just thought I'll put this slide up here so you can see some of the partners, or these are the key partners. Also, this is not the entire group of researchers in our Center for Development and Implementation of Point of Care Diagnostics at the University of Pretoria. However, I've put researchers that are leading different components of our center. And these are probably faces that you're familiar with, and people you can easily contact and ask questions about our center. So you have them here on the slide. I don't think I have much of the time, because I also want us to discuss if we can be given time. So you can see them on the slide, and their names are there, and some of them you're familiar with. This is a picture that we took in one of our symposium, and it has our mentors and our collaborators, and as well as some of our team members that you did not see in the picture. And I thank you, colleagues, and thanks for listening, and I'm happy to take questions.
Thank you very much, Professor Mashamba-Thompson. I think listening to you has been so great. You can see the amount of applauses and from all attendees, hearts as well. So people really love this, and the comments in the chat box say a lot, actually, about the teachings. Listening to you brings a number of adjectives in my mind. Things like fluent, eloquent, passionate, expert, knowledgeable. I'm sure others can add a lot of other adjectives. that come to mind. Just listen to the passion in your voice, but also the knowledge that you shared with us today. I'm going to leave the thank you to Dr. Shin, my partner and co-worker, Dr. Shinas, at the end to do when he does the vote of thanks and comments and closing remarks. But for now, let me hand over to our attendees. We had a lot of them today. I think when I last counted, there were 496 in the room. Thank you very much, Prof. It just shows the interest, especially the topic that we seldom hear about, but that we must hear about, especially this day and age. I think this was an eye-opener. I see quite a number of questions in the chat box, but those who would like to raise their questions orally may just raise their electronic hands. We'll recognize them. And you then be allowed to unmute yourself, and you may put your question or comment orally if you'd like to. But maybe let me start with those that we have. Prof, I think there are quite a number already. I'll just go maybe in random. Just the first one, the point of care diagnostics test, are they already linked to NHLS system? Are they, to the, can one get NHLS reportings and reports from the pathologist in the laboratory from point of care test, number one? And what about, NHLS usually means public health hospitals, but, we have a lot of people from the private sector here as well. So there are the Lancets and the AMPATs and the PathCares and others. If you can comment on that initially.
Thank you. Thanks for that question. You saw in one of the areas that one of the areas that I thought is problematic is poor integration, right? So we have a point of care accessible in many settings. You can go to a pharmacy clinic, which is not an NHLS lab or linked clinic, and get a point of care and get a result there, then that's not linked to the NHLS system. But if you are in a primary healthcare setting or a hospital setting, in most cases, the point of care diagnostics that are there will be linked to NHLS system, but not all. There are point of care diagnostics tests that are just linked with the Department of Health system, not accessible. Those results are not linked with the NHLS system. So there is fragmentation, and we do need to find a way of integrating this. Because, there's a lot of data that is all over the place and data that could be useful.
Okay, there's a question from Dr. Zukiswa Panipinini, who says, are there any point of care POC diagnostics tests for malaria? And also, who does the calibration of these instruments?
Yes. Thank you, Zukiswa, for that question. So when we mapped the availability and accessibility of point of care tests in KZN, because we just use KZN as a model, there were malaria tests, but they were not in all. So I can tell you that in some clinics, malaria tests are there. And I'm just assuming that the implementers or the Department of Health just maybe map regions that need such tests and make sure that they are made available. But those are available in some clinics, not all. And the calibration of these tests. So if it's a rapid test, a lateral flow test, it doesn't need calibration. Everything is inbuilt. There's a QA systems, everything is there. But it's not a machinery also that requires calibration. We do know that there are equipment now I'm outside of malaria in general. The equipment now are made available to point of care settings that require calibration. In most cases, in cases like that, you find the training is provided to the users, but that training also is not so effective. You find the test is being used without calibration because the users are just being shown, you can do this, you can do it this way. If you want to clean it up, you clean it up like this. If you want to calibrate, you calibrate like this. But you're talking to someone who's not been taught on in depth about the quality management systems of laboratory testing, and just like me, when I'm using my scale at home, that's how they tend to use these machineries and they don't. I don't have an understanding of the engineering behind that. So there is a need really for, when we did the research in the clinics, the health providers there did admit that they're not doing all of these calibrations for some of those equipments, and they know that should be done, but they don't feel it's their work. It should be its laboratory staff work. So if anyone wants them to calibrate and do all of those kind of work, which they're not trained on, then they should bring laboratory technicians or laboratory technologists to also be based in the clinics, which I agreed with them, because I mean the 3-year training that they were offered didn't incorporate the quality systems management of laboratory systems. So yeah. Next questions.
Okay. That's right. Yes, there are quite a number of questions. So we'll try to go through them in the next 10 minutes. But there's a question from Dr. Monica Makai, which says, is a point of care diagnostics extendable to veterinary science, and stroke zoonotic infections?
Okay. Thank you very much for that question, Monica. Yes, we have lots of tools now that are used for animals and for human to test the same disease. So if you're looking at a zoonotic disease, you want to see whether there's in the region, this disease, is it detected in human and also in animal? So you do have diagnostics tests that are used for zoonotic diseases. They're just not many. In most cases, they are being used for research because our systems are so slow in the uptake and that. So if you were to go to a clinic to test for that zoonotic disease, you will have to have your samples sent to the central lab and probably arrive in the lab with poor sample integrity and not be tested. And then by the time they say they want a second sample from you, you are dead because you were given wrong treatment in the time that you were waiting. So that's why we do need to scale up and improve accessibility of these existing already available diagnostics. They are there, I can tell you, but they are only in the research space.
Okay, there's a question from Dr. Kamileng Mukonwana, who says, for a new laboratory, where and how can one find out what tests are required or are in demand in a specific region? You know, what tests would you have? What POCs would you have? Or besides just asking doctors?
Yes. Okay. Yeah, you have to conduct a thorough survey, of point of care tests. So we've done that in KZN a long time ago. We do need to repeat that survey because it actually needs to be done at national level and so that we can inform the developers and inform the distributors on what exists and what still needs to be made available.
Yeah. Okay. Let me ask this one. The point of care diagnostics are, what is the view of medical schemes? Do they pay for them? Do they have ICD-10 coding?
Thank you for that question, and we do need to get them to be here also to answer that question. So I have not been in practice and using point of care diagnostics, so I am not sure. Perhaps if we have a laboratory managers here who are in practice and offering the services using point of care diagnostics. Usually what I do know, I was in the lab in the past and I also work in the lab every now and then. You will not show that I use point of care diagnostics when you now submit your form for a claim. You will just say you've tested you've tested the patient. You show the test that you've done, DNA extraction or PCR. You won't say it's a PCR that is a point of care or PCR that was this size of a machine. You will just state the actual test that you've conducted. So I don't know how to answer that question. I don't think when you are making a claim, you have to specify the type of test of machinery that you use. You specify the procedure that you've done. And that could be done by a point of care diagnostic or a lab-based diagnostic. And I'm sure some of the laboratories are using rapid diagnostics as well and still claiming, I don't think that should be an issue.
Okay, I see we've got a hand. Maybe someone is offering us an answer to that question or something. But you can go ahead. I think it's Dr. Adel Jayan. I hope I'm pronouncing your surname correctly. Please unmute
good evening,
yourself.
colleagues.
That's right.
Good
you
evening,
can go
colleagues.
Ahead. Yes.
Okay,
go
thanks
ahead.
very much. I hope you can hear me. Yeah, thanks very much for your wonderful presentation, Prof. My concern is actually in the area of clinical skills at the present compared with 10 years ago. When it comes to clinical skills, it's really nosedived. If now we encourage point of care diagnostics, what's your take on its effect on clinical skills of clinicians? Thank you.
Prof. Mashamba-Thompson, I hope you heard the question. You want to comment? Thank you.
Yes, I truly believe that in enabling having access to point of care diagnostics, clinicians that will have access to point of care diagnostics will have enhanced clinical skills. They will be able to diagnose the point of care diagnostics, as I said, it will inform the clinical intervention that they should they should implement on a patient. So the clinical decision making will be enhanced. So you're not just gonna, look at the patient and then play the sangoma that sometimes you do. You will be able to take a sample, conduct run a test, and have a definite answer as to what this patient is presenting with. And not just be saying, I see your eyes are like this, and yes, your hot temperature, and then you now say, here's an antibiotic. That's being a sangom. How do you know that I'm suffering from something that needs antibiotic? So I think the clinical skills will be enhanced.
Yeah. Okay. There is a question about I think it's a multi prompt questions. I think actually 3 questions in one from Dr. Makai again. I think I'll take them one by one. When will these tests, the POC diagnostic test, stop being just a screening test, but being actually and more of diagnosing of disease so that you can start treatment immediately?
Absolutely. Thank you very much for that question. It's an important question. Yes, we have too many of them that are just for screening, but we also have more that are emerging and coming through now that are diagnostic. But most of the ones that are enabling us to diagnose and definitely at the point of care, it's the molecular-based tests, and there's an increase in development and also deployment of molecular-based tests. We have many of those now. So yeah, and the only problem with molecular-based tests, there are a few more steps that needs to be done before you can actually conduct the test, but that hurdle can be overcome through training.
Yeah, I think Dr. Monica also says, how accurate or specific or sensitive are these POCs? And she goes on to say that she feels that laboratory investigations will always be there, will always have a final say, and she wants to know what you say to that.
Absolutely. I mean, in the context of South Africa, we already know what point of care diagnostics can do and when laboratory then intervenes. We have the largest point of care diagnostic service for HIV, right? It's not always that you do need a lab in detecting and diagnosing HIV. Patients are being tested in the clinics, and there also is a confirmatory test done in a clinic. We don't even need to go to the laboratory. So if we can do it for HIV, we can do it for many other viral diseases and others as well. So we know that, yes, there are times when lab is needed, and then it's not always. We've seen that with HIV, but what I can say, going back to having more of these tests being screening tests, also means there's also going to be a lot more work for the lab, because if we're screening more people, we're detecting a possibility of a disease condition through that screening, through the positive test. Then the confirmatory tests need to be sent to the laboratory. So there's a lot more work for a laboratory. I think maybe we're talking in a context where we're thinking laboratory will lose business. No. Point of care diagnostics, the screening test will mean that laboratories also will double on their business. The more people are screened, the more people will need confirmatory tests.
Actually, this talk about tussle between POC diagnostics and our traditional laboratories reminds me of a time when, in recent years, when we were introducing bedside blood gas analyzers, and the laboratory was furious about that, because they saw it as losing business, because now blood gas analysis was being moved from taking arterial blood and sending it to them, but instead doing it at the point of care. So, that tussle, I think, will always be there. They might feel that bedside POCs may take business from them. Yeah. Okay.
Yeah, but we also we are not business professionals. We are healthcare professionals, and our focus should be on improving health outcomes. Yes, we do have to eat, but I'm sure we can still eat and improve health outcomes.
Yeah, I see the number of questions is increasing as we go on. We'll see how we manage those that are not answered because of time, because of run out of time, will be noted and will be sent to Dr. Mashamba-Thompson to respond to as far as we can. But here's another one. Does the ease of doing these tests that comes with a POCs not always increase chances of over-servicing or over-utilization and over-servicing?
You mean the ease of, you mean ease to use or over-servicing of the test? Or
because they are available, they are bedside, if they are there for the doctor who can do the test there and then, is there no chances of over-servicing, meaning that you do test even when they're not actually needed, but because the test is there next to you, you just do it. Yeah.
Yes.
And that could increase costs. That could increase costs as well. Over-servicing.
Yes, absolutely.
Yeah.
Yes, absolutely. Yes, I think, as health professionals, we're well trained, right? We also do know when you're not going to just do things for the sake of, I want to play with this machine. I believe that a health professional will assess, when they need to use the test and when it's acceptable for them to use the test. Our health professionals have access to these tests already, and you don't go to a doctor or to a clinic every day and then just because they have a box of HIV tests, they just offer everyone an HIV test. So South Africa we've mastered this. I don't think suddenly, because now beyond HIV tests, we are going to have 10 more additional tests, will start misbehaving. Our health professionals are not misbehaving even with the point of care tests that are available to them now. They are able to assess when the test is needed and they use that test. Maybe the cases are out there where there is abuse, but we've not heard of that yet.
Okay. Yeah, Dr. Lady Maulaulwe. Molaudwe. My apologies. It says, my apologies, Doc. How far are we with the POC diagnostics with regard to tuberculosis, TB?
Oh, wow. So yeah, that's been around for a long time. You've heard of Gene Expert, right? So we have point of care diagnostics for TB. I know that there are some that have been rolled out in KZN and are now being implemented already. I have a student who's even working on evaluating the quality systems management of those tests in KZN in the few hospital clinics that are being used to pilot. So these tests, I mean, there's a lot that they've been developed a long time ago. The issue is most of these are molecular-based tests. So we know that there is a challenge. There's a few steps before you test in a molecular-based test. So hence we are very much interested in seeing how the quality is maintained in the clinic now that the tests have been deployed now at point of care. But I believe that the deployment of the test is also done alongside training. But I am yet to find out that in the study that we're conducting in these clinics that are piloting to see whether the quality is being maintained and the systems are being followed.
Yeah, I think there's a question about cost comparison between POCs and traditional laboratory diagnostics, but I think that would be, in my mind, I think that should be obvious. Laboratory tests would be more expensive, am I right? Okay.
It's not as obvious as that, Prof. We also look at at other things such as
I'm not yet Prof. Just
yes, no, but I mean, like
remember,
if the argument is to improve access to healthcare, right? Would you be counting the price of a test or counting the number of lives that are being saved? So I've not really, I don't even spend too much time counting how much it costs. I count more how many lives are being saved by accessing diagnostics. So we do know that the prices in terms of a lab test, you have to count transportation of those tests. And even if the transportation is cheaper than point of care, if the test is transported from my village in Milamula there in Limpopo to Polokwane in the heat and in the cooler box, by the time it reaches that molecular biology lab in Polokwane, integrity of that sample is lost. So I don't see how we can even get to a point where we are counting which one costs more. Let's count the number of lives that are being saved by accessing diagnostics.
Okay. Dr. Nathaniel Mofolo says, any advances in point of care testing for cancer? For cancer screening, and he mentions specifically prostate cancer.
Oh, thank you very much, Dr. Mfulo. I forgot to mention the work that we are doing in that regard in collaboration with Numeri, the basic and translational research team. So as far as I'm aware, I don't know of a test that exists. I know there is work that has been done on liquid biopsy, and it's still in a research stage. In South Africa, I don't know of a test that exists for prostate cancer as a point of care test. I know that, it's possible to develop that because it's there in chemistry, prostate antigen test is there. So I don't know of a point of care test in South Africa for the prostate antigen.
Okay, let's take the last one. I think a short one. He says, I'm impressed with, no, not that one. He says, my question is, are there any POC diagnostic tests for non-communicable diseases like diabetes, etc.? Well, I think for diabetes, I think glucometers, we already have glucometers, but maybe do you
Yes.
want to respond to that?
Oh, that's one of the tests that we even use as an example, hey, because we know that a few of us have even relatives that use that test at home. So there's too many of those, and yeah.
Yeah, the answer is yes for some of the non-communicable diseases. Yes, that's right. They're good examples. All right. Thank you very much, Prof. Mashamba-Thompson. I'm going to hand over to my colleague, Dr. Who's also our Chief Medical Officer, Dr. Burton Shinas, to take over and do the closing. Dr. Shinas, over to you, please. Thank you.
Thank you, Dr. Kinoshi. We've met. In the first thing that I know you said that, Prof, that you're not good with people because you're only working in the lab. But when we started communicating, you immediately started giving me your first name, and you made me feel so, you were just welcoming. So thank you so much for your manner and your approach, and how you see people. We often get caught up in, like you said, the complexities of healthcare, but at the end of the day, there's a human being, there's a person who comes to us for care. So thank you for emphasizing that. I just have a quick question for you before I close. How does anybody become part of the SACSS? Because you kept emphasizing that you make training available, that you are able to help and mentor. And I know that you're part of this society, which I'll give more information about shortly. But how does anybody become part of that? Anybody here, how do they contact you? How does it work?
Oh, thank you very much. And also, it's great to see your face because we've been talking on email. And also, just as a small correction, I said I used to work in a lab, and it's more than 10 years ago now that I'm in a public health space. I've learned to interact with people a lot more. So it's been like it's my previous life in the lab. And so, your question about how to get hold of us. Colleagues, if you type my name on Google, you'll find you are likely to find my LinkedIn, and you can contact me through LinkedIn, or you can email me directly at Tivani.Mashamba-Thompson. So my full name, as you can see it, at up.ac.za. We do have a center email address, but it's yet to be activated. So when that email address is activated, it will be great, because if you email that, you'll be able to get a quick response. Even if I'm not responding, it will be other people responding. So yes, we're happy to collaborate and work with anyone.
Yeah, just for information for all the attendees, who I thank for joining and staying with us to the very end. The South African Clinician Scientist Society, they were launched in 2018, and the president is Professor Salome Maswime, and she's also the head of global surgery at UCT. And so we reached out, and she mentioned that there were a number of experts and professionals that were prepared to participate in these webinars. And the first person that she nominated and put forward was you, Professor Thompson. So thank you so much for availing yourself and making yourself open for people to approach you afterwards, and sharing all your insights in your research experience. So again, the Cliniques Health Group presents these Thursday evening webinars. So we want to say thank you to the Cliniques Health Group for putting this together. That's a free sponsorship, so anybody is able to attend free of charge. And then the team behind the scenes, as you met them earlier on, they're there to make sure that everything works efficiently and effectively, and be able to communicate. I see a lot of thank yous, and I see a lot of hearts, and people are blowing kisses your way. So we also want to say thank you very much for everybody attending to the very end. Dr. Kinoshi, I know you don't see yourself as a professor yet, but I'm sure when people interact with you, they see you, we have a lot of high regard for you. It shouldn't be long from now. To the attendees, once more, have a blessed evening, and please join the rest of your families, and we look forward to seeing you next week, Thursday, at 6 o'clock for another remarkable presentation by the Clinics Health Group webinar presentations. Thank you so much, everyone. Have a good evening.